Welcome back to Decode Healthcare with Harshal. All right, let's jump right in because today is the grand finale of our 8-part respiratory system explainer. You know, you've already battled through the nose, the larynx, the trachea, and last time we conquered those massive open lung resections. But now we're setting a fierce, highly focused tone for the absolute final frontier of pulmonary surgery. We're talking codes 32701 through 32999. If you want to code at an elite level, this is exactly where you earn your stripes. So let's get to work. So, here is the central mystery we really have to solve today. How on earth do you code a single life-saving surgery that is just so massive it actually requires 3 entirely different phases of physician work? We're talking about procedures that sometimes involve 2 separate bodies. We're transitioning away from the straightforward excisions we covered last time and stepping right into the absolute boss fights of medical coding. To conquer these codes, we absolutely need a clear mental map. Here is our agenda for today's explainer. First up, radiation and repair. Second, the 3-part transplant. Third, surgical collapse, which is also known as thoracoplasty. And finally, number 4, tumor ablation. Starting with Section 1, stereotactic radiation and repair, which covers codes 32701 through 32820. Now, what's super interesting about code 3271 is that it isn't actually the radiation delivery itself. This code is specifically for the surgeon identifying and delineating the exact borders of a tumor for stereotactic body radiation therapy, or SRS/SBRT. They are literally drawing the map for the radiation oncologist. And the absolute golden rule from your CPT guidelines, you only report this target delineation once per entire course of treatment, even if that treatment ends up requiring multiple sessions. Moving right along, we hit the major chest repairs. Picture a patient coming into the ER from a severe car crash with major trauma. We aren't just talking about simple stitches here. Surgeons are closing massive chest wounds or repairing torn lung anatomy just to restore a critical airtight seal. You've got code 32800 for fixing a lung hernia that's popping through the chest wall, 32815 for closing a major bronchial fistula, and 32820 for major post-traumatic chest wall reconstruction. All right, Section 2, the 3-part transplant, covering codes 32850 through 32856. Take a deep breath because we have officially arrived at the biggest coding lesson in this explainer. The complexity here is off the charts. The CPT guidelines state this very clearly. Lung allotransplantation involves 3 distinct components of physician work. A transplant isn't just one magic catch-all code. To get it right, you have to capture the exact specific work the physician performed. Let me translate that dense guideline text into plain, simple English for you. Think of it as the rule of 3. Phase 1 is the harvesting. That's the cadaver donor pneumonectomy, where they physically remove the lungs from the deceased donor. Phase 2 is called the backbench standard work. This part is honestly fascinating. The surgeon is literally working on the donor lungs in a sterile cooler packed with ice, meticulously trimming the blood vessels and airway so they fit the recipient perfectly. And finally, phase 3 is the implantation, where those newly prepped lungs are actually sewn into the recipient's empty chest cavity. So, the crucial point for us is knowing the exact difference between those first 2 phases. Code 32850 is strictly for taking the lungs out of the donor and preserving them in cold solution. But codes 32855 and 32856, those are for that meticulous backbench work we just talked about, dissecting the tissue to prep the cuffs and arteries. You'd use 32855 if they're prepping a single lung and 32856 if they're prepping double, bilateral lungs on that backbench. Now, what about phase 3? That's the actual implantation into the recipient, and the codes range from 32851 to 32854. Whenever you're reading an operative report for this, you just need to ask yourself 2 simple, distinct questions. Number 1, was it a single or a double lung transplant? And number 2, was cardiopulmonary bypass used during the surgery? The answers to those 2 questions will literally point you straight to the correct code. Okay, let's shift gears. Section 3 is surgical collapse therapy, historically and clinically known as thoracoplasty, and it covers codes 32900 to 32960. Now, I know it sounds completely counterintuitive. Why on earth would a surgeon intentionally collapse a lung space, right? Well, thoracoplasty is the permanent surgical removal of portions of several ribs. And without the structural support of those removed ribs, the chest wall literally caves inward. Surgeons do this to intentionally obliterate an infected or highly diseased pleural space, kind of like a massive cavity caused by severe tuberculosis. Collapsing that space is what finally allows the body to heal. When you're coding a thoracoplasty, your selection entirely depends on the exact technique used by the surgeon. Code 32900 is for an extrapleural resection of the ribs, meaning it happens outside the pleural cavity. Code 32905 is for a much more extensive Shada type or extrapleural thoracoplasty. And hey, keep an eye out. If the surgeon is performing this collapse therapy specifically to close a bronchopleural fistula, you'd actually bump down to code 32906. Section 4 brings us to other procedures, tumors and ablation, spanning codes 32994 to 3299. We are officially in the home stretch. Let's cool down this explainer by looking at advanced targeted ablation therapies. Code 32994 represents cryoablation. The surgeon inserts specialized needles directly into a pulmonary tumor under imaging guidance. Then extreme cold is applied, literally forming an ice ball that destroys those cancer cells from the inside out. So you essentially have two primary weapons against these tumors, and you must code the correct energy source. As we just said, code 32994 is cryoablation, freezing the tumor. But if you see code 32998, that is radiofrequency ablation. That means the doctor is using a specialized needle probe to emit heat waves, effectively cooking the lung tumor from the inside out. And remember, both of these codes already include the imaging guidance, so absolutely do not code that separately. Oh, and there is a critical guideline note right beneath these ablation codes that you just can't miss. If the physician performs this ablation on pulmonary tumors on both the left and the right sides during the exact same session, you report the code with modifier 50 for a bilateral procedure. Accuracy with your modifiers is exactly what separates good coders from truly great ones. And with that, massive congratulations. You have survived the entire respiratory system masterclass. But honestly, ask yourself this. If managing the air spaces and collapsing lungs required this much precision, how complex do you think the pressurized, high-stakes plumbing of the human heart is going to be? If this explainer helped you decode the guidelines, make sure you're subscribed, because next time we face an absolute beast, the cardiovascular system. Get ready to master the human heart. I'll see you there.